May I invite another speaker, please? It's Kirsten Davidse from the Netherlands, and the topic is the misdiagnosis and health problems in adults with Prader-Willi syndrome, recommendation for screening and treatment. Thank you.
Perfect. Good afternoon, everyone. My name is Kirsten Davidse, and I'm a nurse practitioner. These are our disclosures. So I'm part of the Center of Adults with Rare Genetic Syndromes in a hospital called the Erasmus Medical Center, the biggest hospital of the Netherlands, situated in Rotterdam. And as you can see, Rotterdam is a city on the west coast of the Netherlands. Really tiny country. It fits 185 times in Australia, so bear this in mind. And as I was telling you, I am a part of the Rare Genetic Syndrome Center. And I'm not doing this by myself. I have 3 wonderful colleagues from left to right. You can see Jacqueline, she's our physician in training. Then you see Janneke, she is a geriatric physician focusing on problems in the geriatric generation, people with Prader-Willi syndrome. So a lot of research is being done by our group on this part. Next up is Laura de Graaff, the founder of the Rare Genetic Syndrome Group. And on the right, myself, and I focus on the transition from pediatric towards adult care as a nurse practitioner. So since the start of our center in 2015, we've seen almost 1,300 new patients with various rare genetic syndromes, of which 200 with Prader-Willi syndrome. So during this talk, I'm going to give a summary of the various research we have been doing in Prader-Willi adults, patients with Prader-Willi syndrome adults. And one of them was investigating the frequent health problems. So these are health problems who are frequently seen in adults with Prader-Willi patients. Not all the patients have been treated during childhood. This is research conducted in 115 adults only in the Netherlands. And as you can see, hypogonadism is the one with the highest prevalence. And of these 54 patients percentage of missed health problems, there were 43 who didn't get the diagnosis of hypogonadism. And if you know, hypogonadism is a lack of sex hormones. The prevalence of hypogonadism is 89% in male and 49% in female, both primary, central, or a combined form of hypogonadism. And not having enough sex hormones can induce growth retardation, the absence of delayed of puberty, reduced or loss of muscle mass, and reduced bone mineral density. And this second thing, reduced bone mineral density, in the long term causes osteoporosis. So one of our articles also focused on bone health in adults with Prader-Willi syndrome. And the mean age of patients diagnosed with osteoporosis was 45 years old. Age was not a significant factor. Bear in mind, this research is being done under several expertise centers where hypogonadism probably was rare. Most of the patients have been treated with sex hormones in those centers after diagnosis. So this is probably because osteoporosis was not so frequent in the young groups, because research has shown a significant improvement of bone mineral density in both men and women with PWS after the start of sex hormone replacement therapy. Although we give a lot of sex hormones, we also see Still, a lot of older patients being referred to our center who do not get, for example, testosterone in males. Probably few years ago, many years ago, prescribing sex hormones, prescribing testosterone was a little bit controversial because everybody thought it gave behavioral problems. So recently I saw a male, 49 years old, with severe fractures, and he was treated for his osteoporosis, but nobody was treating him for his hypogonadism. So the question we clinicians have to ask ourselves, in my opinion, are we providing optimal osteoporosis treatment if we do not treat the underlying hypogonadism? Going back to the recommendations we are giving in our article about the misdiagnosis of several frequent health problems. And as you all know, Prader-Willi syndrome is a hypothalamic disorder. So a lot of the pituitary hormones are working less or not optimal. As mentioned, hypogonadism is really frequent. So we're recommending to annual measure sex hormones and ask about menstrual periods in females. Hypothyroidism is still frequent, and also this is a recommendation to measure thyroid hormone. On the other hand, adrenal insufficiency was rare in our research. And I don't know if the guidelines in Australia are the same, but in children with Prader-Willi syndrome in the Netherlands, they get hydrocortisone for stress situations. And I don't know if you know the side effect of hydrocortisone, but one of them is weight gain. So our recommendation for adults with Prader-Willi syndrome is to no need for standard screening in adrenal insufficiency and no need for standard treatment as well. Hyperprolactinemia was frequent, although mainly with the use of medication, especially with antipsychotics. You can measure it in blood, but there is no additional scan necessary. And growth hormone treatment, heard a lot about it. The last question was about it. Improves cognitive body composition, and also consider treatment in adulthood. If you'd like to know more about the misdiagnosed and health problems in adults with Prader-Willi syndrome, you can search on this article, and it's also been hung up on with the posters, I hear. Okay, perfect. Another research we have been done with that is the effect of childhood medical multidisciplinary care and the combination of growth hormone treatments. And we saw a significantly change in BMI as well in diabetes. However, we think that diabetes is correlated to the BMI. As you can see, the BMI was significantly lower in the people who got growth hormone treatment during childhood, as well as multidisciplinary adult care, childhood care. I'm so into adult. Okay, that's nice effects, and we see a new generation coming, but what about the older generation? Is it still useful to treat them with growth hormone, for example, or for other? And as a nurse practitioner in a center for people with Prader-Willi syndrome, adults with Prader-Willi syndrome, I absolutely say yes. Yes, it is useful to treat older patients with the same care childhood patients get. I'd like to let you know, with our complete team, the multidisciplinary patient care team, clinical research, and fundamental research we conducting in our Center for Adults with Rare Genetic Syndromes. Thank you.
Thank you very much. Thank you very much for sharing your experience.
Thank you.
One question. Is there any question for Kirsten? Just one question at the back.
Hi, I'm a parent of a 20-year-old who started on growth hormone, and in Australia it's not really considered that it's a treatment for adults. If it's, and he's now around 6 foot in height. So, you know, people look at him and doctors look at him and say, you know, he doesn't need it anymore. So in terms of arguing, what are the benefits for someone who previously had it as a child? Do you see the same results for adults if they've been treated early years?
A really good question, and also a misunderstanding in growth hormone treatment. So I think there is a difference. Not only, let me start at the beginning. So most of the time, people hear growth hormone treatment. They think, oh, I'm cannot grow anymore, so I don't need it. That's not true. We all make some growth hormone still. It's less, but we need it for our muscle development. We need it for our body composition. That's the main reason as well to start growth hormone treatment in adults. So you see less of the developmental beneficials with growth hormone in adulthood because the brain is already been formed to adulthood. But you do see it in body composition. So, and in my experience, it helps with losing weight, not initially, but because growth hormone tends to give a little bit of fluid retention in the beginning, but after a while, it really helps in body composition.